Hi everybody, welcome to session 2 for the application of pharmacogenetics. Today we're going to talk about psychiatry, neurology, and cancer. And just like the previous session, what I'm going to do is really be highlighting CPIC based guidelines by going through the drug's mechanism of action, how the genetic variation actually influences the drug outcomes, and then what the actual CPIC recommendations are if there are any. So let's get started. First, we're going to talk today by concentrating on psychiatry, and we're going to talk about SSRIs. So what is the SSRI mechanism of action? And what I'm going to do here is highlight a few of the SSRI mechanism of actions that are actually included in the CPIC guidelines. So first, let's set up those drugs. So the 4 drugs I'm going to talk about today are fluvoxamine, paroxetine, S-citalopram, including R-citalopram, so the normal drug citalopram and the actual drug S-citalopram. So we'll talk about that in a second. And then sertraline. So let's talk about fluvoxamine. How is fluvoxamine metabolized and how does it use and exert its mechanism of action? So the first step in fluvoxamine's metabolism is by the enzyme CYP2D6 into fluvox amino alcohol. And then it goes through one more transformation. And that's by alcohol dehydrogenases into fluvoxamine acid. So the parent drug, which is the active form, which I'll indicate by stars here, gets metabolized by CYP2D6 into fluvox amino alcohol, which then gets metabolized by alcohol dehydrogenases into fluvoxamine acid. And then at the end, we'll go ahead and show their actual pharmacodynamic or mechanism of actions on how they affect serotonin. But let's transfer into paroxetine. So how is paroxetine metabolized? Paroxetine is metabolized by CYP2D6 principally, so that's the major metabolizing enzyme, but it's also metabolized a little bit by 1A2, 3A4, 2C19, and 3A5, but mostly by 2D6, and that's changed into paroxetine catechol. And then paroxetine catechol, just like fluvoxamine above, undergoes one more transformation. And that's by various CYPs and other enzymes into the inactive form, which is then removed from the body. So paroxetine is principally metabolized by CYP2D6 into a secondary, less active metabolite, which then goes into a further inactive form to be excreted. Paroxetine would be the parent molecule as well. So I'll put stars here indicating that is the principally acting molecule. Now what about citalopram and S-citalopram? So, citalopram itself comes in an enantiomer racemic mixture of R and S citalopram. R citalopram is the less active form here, so S would be the more active form, kind of similar to what we learned about warfarin. S is super, but the R form gets metabolized by 2D6 into an inactive form which gets excreted, while S-citalopram, which is also the actual parent compound of S-citalopram, the drug, ES citalopram, and that's mostly metabolized majorly by 2C19 and 3A4 with a little bit of 2D6, but mainly 2C19 and 3A4 into S-dimethylcitalopram. And then this further undergoes one more step, and that's metabolism by 2D6 into an inactive form, just like we saw with paroxetine above. So, again, just to reiterate, citalopram itself comes in a racemic mixture, which would be both R and S forms. However, the S form is the more active form, which is why they created a secondary drug called S-citalopram. That's metabolized majorly by 2C19 and 3A4 into S-dimethylcitalopram, which goes into an inactive form by 2D6, and S-citalopram would be that principal parent drug that carries the actual therapeutic effect. Finally, let's take a look at sertraline. Sertraline itself, which would be the principally acting drug with the mechanism of action, the therapeutic effect, is mainly metabolized by 2C19, 3A4, 2D6, but mostly 2C19 here, into desmethylsertraline. Well, there's actually a secondary pathway, a minor pathway, which is metabolized by MAOs, so monoamine oxidases, and UGTs to create an active form. And then desmethylsertraline itself actually undergoes one further metabolism step, and that's by MAOs and CYPs itself to create an active form as well, which is prepared for excretion. So sertraline, majorly metabolized by 2C19 into the less active form, desmethylsertraline, which then gets changed into inactive forms and removed from the body. So how do all of these drugs work? Well, they have to cross the blood-brain barrier. So they have to come in from the blood and cross into the blood-brain barrier, where they actually have their pharmacodynamic and therapeutic effect at the synapses and what SSRIs do, and this is actually contained in their name, selective serotonin reuptake inhibitors. They prevent the reuptake of serotonin in the synaptic cleft back into the presynaptic neuron through SLC transporters. So you can see here, they block the transporters from transporting 5-HT back into the presynaptic neuron, therefore increasing serotonin concentrations and theoretically having the antidepressive effect. Now that we've talked about how these drugs are metabolized and how they exert their mechanism of action, their therapeutic effect, let's talk about the actual effect of pharmacogenetic variation on these drugs. So we're going to talk about our 5 drugs here being paroxetine, fluvoxamine, S-citalopram, and sertraline. We're going to take a look at what happens when your different metabolizer phenotypes of CYP2D6 or 2C19. So this will be very similar to what we've done in the previous week, looking at the effects of these metabolizer types on these drugs. So the first metabolizer type we can have is ultra-rapid. And with ultra-rapid, we have some differing effects on the drugs depending on the drug we're talking about. So let's see what that is. So for paroxetine, S-citalopram, and citalopram, and sertraline, with ultra-rapid metabolizers, you're going to have decreased therapeutic levels and an increased risk of failure. And that's in contrast to fluvoxamine, which has no data to support any sort of effect of ultra-rapid on fluvoxamine levels or outcomes. So to date, we have no recommendations or any data suggesting a pharmacogenetic effect of ultra-rapid metabolizers on fluvoxamine. Next, let's look at extensive metabolizers. And for all of these drugs, if you're an extensive or a normal phenotype at CYP2D6 or 2C19, depending on the drug we're talking about, you're going to have normal levels and normal metabolism. Now, what about intermediate metabolism? And with intermediate metabolism, you're going to have increased levels because your enzymes aren't metabolizing the drugs as rapidly, and therefore you may have an increased risk of side effects. Finally, let's take a look at poor metabolizers. And poor metabolizers are one step further of intermediate, where you have very increased levels and a much higher risk of side effects as compared to intermediate metabolizers or normal metabolizers for that matter. So those are the pharmacogenetic effects of CYP2D6 or 2C19 depending on the SSRI that we're talking about, which you can glean from the previous slide. And you can see there are the pharmacogenetic effects based on the data for these two genes. Now let's take a look at what the CPIC guidelines are for these drugs based on CYP2D6 or 2C19. So let's again write those drugs out. And this will be based again on either CYP2D6 or 2C19. Looking at either of these genes' specific phenotypes being ultra-rapid, extensive, intermediate, or poor. So first, let's take a look at what the ultra-rapid recommendations are for SSRIs. So for paroxetine, S-citalopram, or citalopram, the recommendation is to seek alternative therapy with a drug that's metabolized by a CYP other than 2C19 or 2D6, depending on the drug we're talking about. Let's take a look at the other drug, sertraline. And for sertraline, they recommend you to use it as directed. However, if there's no response, then you will seek alternative therapy by a different CYP. Finally, let's take a look at what the recommendation is for fluvoxamine. And if we remember from the previous slide, you probably could take a guess of what that is. And there's no recommendation because of that lack of data that we talked about in the previous slide. What about extensive metabolizers? And because we would expect normal levels, population average levels, the recommendation is to use as directed. How about intermediate metabolizers? And the same as extensive metabolizers, the intermediate metabolizer recommendation is to use as directed as well, probably with a caveat of an eye on an increased risk of side effects. Finally, what are the recommendations for poor metabolizers? The primary recommendation is to decrease the dose by 50% and slowly titrate to response. A secondary recommendation is to seek alternative drug therapy by a CYP that's metabolized differently, meaning just like with ultra-rapid metabolizers, for example, if you have S-citalopram, and you're a poor metabolizer, you should try to seek a different antidepressant that's not metabolized by CYP2C19. Finally, I'm going to put a note in here. Well, for all the other drugs, they recommend a decreased dose by 50%. Fluvoxamine's recommendation actually gives you a range of 25 to 50% dose reduction. So a little bit different there for fluvoxamine, maybe gives you a little more wiggle room. However, for all the rest of the drugs that we're talking about here, you decrease that dose by 50%. So in summary, what we saw here with SSRIs with the CPIC guidelines are that if you're an ultra-rapid metabolizer, you're going to seek alternative therapy if you are an ultra-rapid metabolizer and you wanted to use paroxetine, S-citalopram, or citalopram. If you wanted to use sertraline and you're an ultra-rapid metabolizer, you would go ahead and use it. However, you would monitor for non-response, and then you would probably seek an antidepressant that's not metabolized by the way that sertraline is metabolized. And then finally, for fluvoxamine, due to the lack of pharmacogenetic data, there is no rec. For extensive metabolizers, as we usually see, it's used as directed, and that's the same for intermediate metabolizers. And then for poor metabolizers, due to the higher therapeutic levels that are achieved, the recommendation is to decrease the dose by 50% for all the drugs except for fluvoxamine. They say you can decrease it by 25 to 50%, and you slowly titrate to response. And if you end up having too many side effects, for example, then you go to the next step, which would be to seek alternative drug therapy that's metabolized by the CYP that isn't a poor metabolizer for that patient. So we talked about SSRIs in pharmacogenetics and the CPIC guideline. Now let's switch gears and talk about tricyclic antidepressants. So we're going to talk about two mechanisms of actions because there's so many tricyclic antidepressants. The first ones I'm going to highlight on this slide are amitriptyline and nortriptyline. So let's get that written out. And the reason I'm putting these two on the slide is because amitriptyline is actually metabolized by 2C19 into nortriptyline, and both of these drugs have antidepressive effects. Let's see what the other metabolism of these drugs are. So on the amitriptyline side, we have two routes of metabolism. One is to a metabolite that's prepared for excretion or removal from the body through enzymes called FMO3s. The second pathway is by 2D6 into the hydroxy form of amitriptyline, which essentially is kind of an intermediate step, which then is metabolized by UGTs into the metabolite that ends up being excreted from the body. What about nortriptyline? And nortriptyline is metabolized again by 2D6, just like amitriptyline, into the hydroxy form, and you're going to see this a lot with tricyclic antidepressants, which is then further metabolized by these enzymes called ACR enzymes into a metabolite that is then prepared for removal from the body. And both of these drugs have their mechanism of action by the following. And that's similarly to SSRIs, to block the SLC transporters to prevent the reuptake of serotonin, but in the case of TCAs, depending on the TCA, norepinephrine as well. So both of these are blocked by tricyclic antidepressants. Let's take a look at the mechanism of action of some other tricyclic antidepressants. Now on the second mechanism of action page, I'm going to highlight 4 different tricyclic antidepressants. And those 4 TCAs are clomipramine, doxepin, desipramine, and imipramine, where imipramine and desipramine, kind of as we just saw with amitriptyline and nortriptyline, where imipramine is metabolized by 2C19 into desipramine. So let's see the common pathways between these TCAs. The first common pathway, as we kind of saw on the previous slide, is the conversion of each of these drugs by 2D6 into their hydroxy metabolite form. Okay, so just like we saw on the previous slide, 2D6 catalyzes the conversion of each of these principally activating or acting drugs on the serotonin system into our hydroxy metabolites, which prepares them for excretion. Let's take a look at one other common pathway with clomipramine and doxepin. And that's where clomipramine and doxepin are converted by 2C19 into desmethyl metabolite form. So desmethylclomipramine, desmethyldoxepin by 2C19, which then again goes on to be removed from the body. And how do these drugs actually work? It's the same exact mechanism of action we just saw. Again, there are some differences between the TCAs on the amount that they block serotonin or norepinephrine, but it's exactly the same. And that's where each of these drugs go and block the SLC transporters responsible for transporting serotonin and norepinephrine back into the neurons. So these drugs, to differing degrees, block the reuptake of serotonin and norepinephrine. So what are the pharmacogenetic effects for TCAs depending on the metabolizer phenotype for CYP2D6 or CYP2C19? For TCAs, if you're an ultra-rapid metabolizer of 2D6 or 2C19, we see the same exact thing we saw with SSRIs, where you have decreased levels and an increased risk of therapeutic failure. Similarly, with SSRIs, for TCAs, if you're an extensive metabolizer at 2D6 or 2C19, or a combination thereof, depending on the TCA we'll talk about, and we'll actually talk about those specifics in the next slide, you would have normal metabolism and normal levels. Now, what about intermediate metabolism? And again, exactly what we were seeing in the SSRI guidelines. You're going to have increased levels and an increased risk of side effects because you're having less conversion into those metabolites that get removed from the body. Finally, what would happen if you're a poor metabolizer? You would have even higher levels relative to intermediate or above, and you'd have an even greater risk of side effects. So almost a mirrored example of what we saw with SSRIs in terms of the pharmacogenetic effects on TCAs. These are the outcomes. Now where the differences will come are in the actual CPIC recommendations, where a majority of these TCAs that we talked about in the previous slides actually make recommendations on both CYP2D6 and 2C19 metabolizer phenotype. Well, previously in these SSRI guidelines, those recommendations are only made on one of them based on the drug we're talking about. Because these TCAs are metabolized, if you go back and look at our slides, by 2D6 and 2C19 for about 3/4 of them in their mechanisms of actions and their metabolism, we can actually incorporate both metabolizer phenotypes and genotypes into the recommendations. But before we jump into those combined recommendations, the two drugs that don't have combined recommendations and only have recommendations based on CYP2D6 are disipramine and nortriptyline. So what are the recommendations depending on the metabolizer phenotype for CYP2D6 for these two drugs? And the reason we only have recommendations for 2D6 is because 2C19 doesn't play as big a role in these two drugs. Therefore, the data doesn't allow us to make recommendations based on both sets of genes, just 2D6 for disipramine and nortriptyline. So what happens if you're an ultra-rapid metabolizer of 2D6 for these drugs? So the guidelines actually have three recommendations, which really are avoid the tricyclic if possible. However, if you can't, they recommend you actually pursue a higher dose while also performing therapeutic drug monitoring, meaning that we can look at drug levels in patients on these drugs and actually increase the dose higher than what we usually would, while safely doing so by looking at the blood levels that they achieve. And kind of along with the first one here, consider an alternative drug not metabolized by 2D6 if at all possible. What are the recommendations for extensive metabolizers for these two drugs? And that's just to continue with the normal recommended doses and use as directed. What are the recommendations for being an intermediate metabolizer for treatment with disipramine or nortriptyline based on 2D6 phenotypes? And that's to decrease the dose here, right, because we have more drug hanging around by 25%, and then again to do that therapeutic drug monitoring because we have that capability with tricyclic antidepressants. Finally, what are the recommendations for poor metabolizers? And the recommendations, if you're a poor metabolizer, are to avoid the tricyclic due to the side effects, so similar to what we saw with ultra rapids, but this time it's due to side effects. Rather, with ultra rapids, it was due to inefficacy. And to consider an alternative antidepressant not metabolized by 2D6 for these drugs. But if you really do need these drugs, maybe they've had some benefit in the past, or maybe they're having partial benefit, we see that a lot, then you go ahead and you're shooting to decrease the dose by 50%, maybe with your final dose or your initiating dose, or even with your dose increases, and to monitor that again with therapeutic drug monitoring. So with these two tricyclics, disipramine and nortriptyline, based on CYP2D6 metabolism, because that's the best data we have, and that's the principal metabolizing CYP within these drugs, For ultra rapids, you're going to avoid the TCA, but if you really need to use it, you're going to perform therapeutic drug monitoring along with it. For extensive metabolizers, you're going to use a normal dose, use as directed. For intermediate metabolizers, you're going to go ahead and decrease that dose by about 25%, but continue to monitor blood levels. And finally, for poor metabolizers, you again want to avoid the tricyclic if possible. Consider some sort of alternative. But if you really need to use it, you want to shoot for a dose that's about half what you would usually use, but you would again be doing that therapeutic drug monitoring, looking at the blood levels of the drug. Now let's transition and take a look at the combined recommendations for CYP2D6 and CYP2C19 for our remaining tricyclics that we haven't talked about. Now the recommendations for tricyclic antidepressants through CPIC using both CYP2D6 and CYP2C19 are a little more complicated. So this is going to look a little different than what I usually do, but let's go ahead and walk through it. So these guidelines, if you go ahead and pull up the actual CPIC guidelines, which I suggest you do as well to compare with the table with what I'm writing down here, is actually just for amitriptyline. However, the footnote specifically states that those guidelines or those recommendations for that table with amitriptyline based on CYP2D6 and 2C19 can also count for clomipramine, doxepin, imipramine, and trimipramine. So let's start to set this up. And the way I'm going to go over the CPIC guideline recommendations for TCAs is to give you the recommendation as a group, put down the strength, and then the corresponding phenotype combinations for that particular recommendation. So let's start with the first recommendation. And that's to avoid use. Now let's take a look at the strength and the phenotype combinations for which you should avoid the use of amitriptyline or the other TCAs listed here. And as you can see here, there's several different combinations on which they recommend you avoid use of these particular tricyclic antidepressants. And the strength of the evidence of the recommendation of the based on the evidence is optional. So these aren't required or strong evidence recommendations. They're considered lower evidence recommendations, but still recommendations that you can consider as optional. So avoid use with someone who's a 2D6 ultra-rapid metabolizer in combination with either 2C19 ultra-rapid metabolizer, 2C19 intermediate metabolizer, or 2C19 poor metabolizer. So 2D6 ultra-rapid metabolizer with any of these three 2C19 phenotypes. Additionally, a 2D6 intermediate metabolizer with a 2C19 poor metabolizer. You want to recommend that you avoid use of these TCAs. And then 2D6 poor metabolizer with a 2C19 ultra-rapid or poor metabolizer, you want to avoid use again. So several different combinations here. This is the biggest group of recommendations within the table. Now let's begin to look at the next set of recommendations. The next recommendation tells you to consider an alternative antidepressant not metabolized by 2C19. So really something that's being driven by 2C19 phenotypes here. Let's go ahead and take a look at what those are. So when you are an ultra-rapid metabolizer of 2C19 in combination with either a 2D6 extensive or intermediate metabolizer, they recommend you consider an alternative drug not by 2C19, and that would be, as you can expect or suspect, that it's because of the increased metabolism causing lower levels of the antidepressant. Therefore, it's probably not the best choice. So that's why they're telling you to find a different drug that isn't metabolized by 2C19. Let's go ahead and take a look at the next recommendation. And this recommendation says to avoid use if possible. However, if you are using, increase the dose with therapeutic drug monitoring. So let's take a look at what combination of phenotypes this exists for. And that's the combination of a 2D6 ultra-rapid metabolizer, so again, causing lower levels of drug, with a 2C19 extended metabolizer, and the evidence here is strong. So a little bit different than the previous recommendation, where if you had a 2C19 ultra-rapid metabolizer, they actually tell you to consider a different drug, but the level of evidence here is optional, meaning that it's not quite as strong. But here there's sufficient evidence to suggest that you could avoid use or use therapeutic drug monitoring for someone who has a 2D6 ultra-rapid metabolizing status, along with 2C19 extensive metabolizer. Now, let's take a look at the next recommendation. And this one goes in the opposite direction of the preceding recommendation, and that's to avoid use, but if you are going to use it, decrease the dose by 50% and consider the use of therapeutic drug monitoring. So let's take a look at what combinations of phenotypes this exists for. And again, as you may have suspected, if you're decreasing the dose here, that's the recommendation, you're likely having higher levels of drug on board due to poor metabolism. So there's strong evidence to recommend this for 2D6 poor metabolizers with 2C19 extended metabolizers. There's moderate level of evidence to recommend this for 2D6 extensive metabolizers and 2C19 poor metabolizers. And then finally, there's an optional level of evidence to recommend this for 2D6 poor metabolizers with 2C19 intermediate metabolizers. Now let's go ahead and take a look at the rest of these recommendations. Now continuing on with the slide, we have two sets of recommendations remaining. Let's take a look at what they are. The first set of recommendations says to decrease the starting dose by 25%. Let's take a look at which phenotype combinations this exists for. And it exists as a moderate strength recommendation for 2D6 intermediate metabolizers with a 2C19 extensive metabolizer combination, and an optional level of evidence for 2D6 intermediate metabolizers along with a 2C19 intermediate metabolizer. Finally, let's look at the last recommendation. And this is the one we always expect to see at least at some point during a CPIC guideline, and that's really just to use that population normal dose or just to use as directed. And let's see which combination of phenotypes this exists for. And that exists for a 2D6 extensive metabolizer with a strong level of evidence in combination with either a 2C19 extensive metabolizer or a 2C19 intermediate metabolizer. So if you have one of these two combinations of genotypes or phenotypes, then you would use that normal dose. You would use it as directed. So again, I encourage you to go to the actual CPIC guidelines to see what their table looks like. This is how I group the recommendations for you guys to look through. Go ahead and rearrange them and put them together for however it makes sense. You could group them like I did by recommendation. You could group them by different phenotype combinations, etc. But when you're starting to incorporate more than one gene into the pharmacogenetic recommendations, it can be a little complex. So go ahead and take a look at those guidelines. Now, in psychiatry, we've talked about SSRIs and tricyclic antidepressants. Let's talk about one more with atomoxetine. So let's take a look at how atomoxetine, that ADHD drug, works. So the main route of metabolism for atomoxetine is through CYP2D6, and that creates a hydroxy metabolite similar to what we've seen with the TCAs, which then again gets metabolized one more time into metabolites which are prepared for removal from the body. So this is the main pathway of metabolism, and CYP2D6, although there's other CYPs at play, is the principal CYP at work here. Now let's take a look at some other minor pathways for atomoxetine metabolism. And this time, going through this entire minor pathways metabolism, you first have atomoxetine metabolized by 2C19 into N-desmethyl atomoxetine, which again, we saw a similar pathway with 2C19 and TCAs. Then we have the 2D6 conversion to the hydroxy form, so N-desmethyl hydroxy atomoxetine. I didn't write the whole thing out there. And then finally, again, a last conversion into a metabolite that's prepared for removal from the body. Then let's take a look at one final pathway, minor pathway of atomoxetine metabolism. And that's the metabolism by 2D6 and 2B6 into the 2-hydroxymethyl atomoxetine form, which again is a less active metabolite, which eventually gets removed from the body. So you can see here, this is the main metabolism that occurs with atomoxetine. And atomoxetine itself exerts its mechanism of action by blocking norepinephrine reuptake in a similar fashion to what we saw with TCAs, so it's a selective norepinephrine reuptake inhibitor. Now that we have that main metabolism route by 2D6 under our belts, let's take a look at what the pharmacogenetic variation of 2D6 has on atomoxetine's pharmacology. And I'll make one note here. And that's that these effects and recommendations are from studies and are specifically for the use of atomoxetine in children. However, the CPIC guidelines themselves actually go through adult-based recommendations, which are fairly similar. So let's take a look at what those pharmacogenetic effects of CYP2D6 are on atomoxetine. So the first route that we always go through is an ultra-rapid phenotype, this time with CYP2D6 or an activity score greater than 2. And the effect on atomoxetine is to have decreased levels, which leads to an increased risk of failure. However, I wanted to make a note on this one, the evidence is weak with this effect. However, it's still a presumed effect. Now let's take a look at extensive. And this one's actually a little different than what we're used to. For extensive metabolizers, those people with activity scores from 1.5 to 2, they actually have a decreased response to atomoxetine if you compare them to poor metabolizers. So kind of interesting there. Now let's continue down the pipeline with intermediate metabolizers. Now, you're probably thinking, I generally don't have this many arrows when we're doing this pharmacogenetic effects. However, that's because it's a little bit special here. So they have this range in here where the guidelines specifically say it's either extensive or an intermediate metabolizer, but the commonality here is an activity score of 1.0 for both. However, there's two different forms this can take. So it's really not known what level of metabolism this CYP2D6 has. So that's why they're saying extensive or intermediate possibly. This first one is when you do not have the star 10 allele. So if you have an activity score of 1.0 without the star 10 allele, you have increased levels but a decreased response versus poor metabolizers. So if we compare that to the extensive effect here, we have a decreased response versus poor metabolizers. However, for this one, we actually have slightly higher levels, but still a decreased response versus poor metabolizers. Then if we look at the next one, which is an activity score of 1.0 with the star 10 allele, this one has increased levels just like the one just before. However, you have an increased risk of discontinuation versus poor metabolizers. So it looks like, for some reason, something's going on here where you have an increased levels, but there's some sort of side effect that might be occurring versus poor metabolizers. Maybe it has something specifically to do with star 10 allele. It's really unknown, but that's what the evidence suggests so far. Now let's take a look at what we'd normally be anticipating here, which is the normal intermediate metabolizer route. And for intermediate metabolizers, those people with an activity score of 0.5, you again have those increased levels. However, you still have an increased risk of failure versus poor metabolizers. So again, the evidence seems to suggest that the elevated levels that one achieves with the poor metabolizers actually has a lower risk of failure. So let's go ahead and see if that holds out. So for a poor metabolizer with atomoxetine through CYP2D6, you have the activity score of 0, right, because you have no activity of CYP2D6. As we would expect, you have much higher levels of atomoxetine, which in itself leads to an increased risk of side effects, again, something we would expect. However, we have an increased response rate versus extensive metabolizers, which we've been seeing so far in kind of the summary of pharmacogenetic effects here. However, you require a lower dose versus extensive metabolizer. So even if you are to lower the dose due to the poor metabolizing status, you still have an increased response versus extensive metabolizers. So atomoxetine has a little bit different kind of pharmacogenetic effects compared to what we've seen so far in all of these pharmacogenetic application examples. Now let's take a look at those CPIC recommendations. Now let's see what the recommendation is from CPIC for atomoxetine if you are a CYP2D6 ultra-rapid metabolizer. And these are a little bit more detailed recommendations than we've seen in the past. Here, if you're an ultra-rapid metabolizer, they suggest that you start with a 0.5 mg per kg per day dose after 3 days, increasing that to 1.2. If no response and side effects at 2 weeks, so you're looking for lack of response, but also no side effects to deal with, then you can go ahead and get that peak plasma concentration. And if it's less than 200, you want to increase the dose to really achieve a level of 400 nanograms per ml. Now let's take a look at what the recommendation is for an extensive metabolizer. And this one's pretty easy. It's the same as ultra rapid. So if you have an activity score of 2 or 1.5 to 2, making you ultra rapid or extensive, you have the same recommendations we just talked about. Now let's take a look at what the recommendations are for this first extensive or intermediate metabolizer. Really, it's arguable in the literature whether or not you're an extensive or an intermediate. This one's specifically defined by an activity score of 1.0 with no star 10 allele. Let's see what that looks like. And this one's pretty easy again. So all that writing up there we did was worth it because for this particular CYP2D6 phenotype, it's the same as the ultra rapid we already talked about. And so let's move on to the next one, and that's the arguable extensive or intermediate metabolizer that does contain the star 10 allele. And here, if you are an intermediate metabolizer with the star 10 present, you're going to start at 0.5 mg per kg per day, just like we did with the ultra rapid. However, you don't do the increase after 3 days, and if there's no response at 2 weeks, that's when you get the peak level, which is 2 to 4 hours post-dose for this particular metabolizer phenotype. And you want to increase that dose until you reach 400 nanograms per ml. But if there are side effects, that means you really should decrease the dose. Let's take a look at what a true intermediate metabolizer with an activity score of 0.5, let's see what their recommendation is. And again, we look out here, this one's pretty easy. It's the same recommendation that we just talked about with the star 10 allele present. So doing that same exact recommendation here above, you would apply to the intermediate metabolizer with an activity score of 0.5. Now let's take a look at poor metabolizer. And this one's pretty easy too, because it's the same recommendation that we talked about here with the extensive/intermediate metabolizer with the star 10 allele present. However, the only difference is that you get the level 4 hours post-dose, not 2 to 4 hours post-dose. So that wraps up the CPIC guidelines for atomoxetine. Now, in terms of psychiatry, I just wanted to mention that there are some future guidelines in kind of the pipeline for CPIC. They will actually give you a list of what's going to come out soon. And so you can see here, there's a pretty lengthy list. There's actually pretty good evidence within psychiatry for future CPIC guidelines. And so here they are, and let's actually go look at what the site looks like. If you go to the CPIC website and click on the Gene Drugs link, it will take you to all lists. You can even download it as a CSV of all the drugs and gene pairs that they have CPIC guidelines on here. So you can see there's the guideline link. However, if you scroll down past the guidelines, you'll start to see kind of a listing here of drugs with high levels of evidence. However, no guidelines currently present, which kind of means that it's in the pipeline. So this is an interesting table just to look at. It's kind of nice. So really, if you're looking at, I would say, B and above, it's likely that that will be put on the short list for a future guideline. Okay, so let's make the transition from psychiatry now into neurology. So let's start with phenytoin. Let's take a look at how phenytoin is metabolized. So the main step of phenytoin metabolism is by 2C19 and 2C9 into what's called phenytoin-arene oxide. And what's interesting here, for specifically the guidelines we're talking about today, there's 2C9 effects, and likely that's because phenytoin's in a racemic mixture where we actually see a preferential metabolism into the S form by 2C9 versus the R form, which may lead to some of the effects that we'll see in the next slide for the pharmacogenetic effects. So of interest, the two forms of phenytoin here are kind of predictive of the main adverse drug events. And so if you have a buildup of the actual parent drug phenytoin, you have dose-dependent ADRs, and that's in comparison to the phenytoin-arene oxide, which is thought to be really a reactive oxygen species, which plays, at least hypothetically they believe, plays a role in the emergence of drug-induced Stevens-Johnson syndrome, toxic epidermal necrolysis, or just in general we call these hypersensitivity reactions, which is something we're always looking out for with phenytoin. Let's go ahead and finish up the metabolism of phenytoin. And the phenytoin-arene oxide, actually about 90% of it gets metabolized into hydroxyphenytoin, while just only 10% gets metabolized into this alternative form of phenytoin dihydrodiol. Then finally, these other compounds are further metabolized hydroxyphenytoin by UGTs into a hydroxy form, which is then eliminated. It's also metabolized into phenytoin catechol, which the other pathway is as well. So despite the differences in the amount of metabolism that phenytoin-arene oxide goes into, they end up both becoming phenytoin catechol, which can be methylated by COMT, which further goes to elimination. But the important here, and the reason I wanted to write all this out, was that phenytoin quinone goes and then forms adducts with certain enzymes. And so this is important because those adducts that phenytoin-quinone ends up forming is another possible theorized mechanism for the hypersensitivity reactions we see with phenytoin. Now, these CPIC guidelines specifically talk about those phenytoin-induced hypersensitivity reactions. However, the actual gene that predicts it is not involved necessarily in the PK that we just talked about. So let's go over what the HLA connection is with phenytoin. And so HLA-B is part of a gene cluster called the major histocompatibility complex. And this is found on chromosome 6. And there's actually 3 classes of the major histocompatibility complexes. And so HLA-B is part of MHC class 1. And so the actual purpose of MHC class 1 is to present peptides that ends up being broken down into peptides, so proteins being broken down into peptides, presents them to the cell surface, which helps our immune system figure out what's our self versus foreign, right? And a lot of times we see this with viruses or other foreign kind of infections that get into the body. So that's really the main purpose of MHC type 1 or class 1. And some other notes for HLA-B. It's highly polymorphic. There's actually greater than 2,000 alleles. So there's really a lot of alleles with HLA-B. So how do we handle all those alleles? Just like with CYP enzymes, there's a star allele system, but it's a little bit more advanced. Let's see an example of that. So the star allele system with the actual HLA genes can have up to a set of 8 digits behind the actual gene that we're talking about. So in this CPIC guideline, we're going to talk about HLA-B star 1502. So you can have up to 8 digits, 8 pairs of digits, so 8 digits total, 4 pairs, that actually define something about the gene variant that we're talking about. In this example, 15 refers to the allele type, while O2 refers to the protein subtype. So a little more advanced kind of nomenclature system with the HLA genes. I just want you to be aware of this is why we see 15 semicolon O2, because it's an actual more detailed numbering system that gives you more information about that particular gene variant. So let's now dive into what are the pharmacogenetic effects on phenytoin. So the pharmacogenetic effects, again, we're concentrating, as mentioned earlier, on the effects of 2C9 metabolizer status. And also of note, these effects and the guidelines themselves also apply to phosphenytoin, so just be aware of that. But let's go ahead and take a look at what those effects are. So if you're an extensive metabolizer at 2C9, you have normal metabolism and levels of phenytoin. Now I know what you're thinking. We haven't done a 2C9 CPIC guideline for a while since warfarin, so why isn't there an ultra-rapid metabolizer here? We usually start with that orange one at the top, right? And that's because there is no known ultra-rapid metabolizer phenotype with 2C9. So therefore, we're not going to go over it because it doesn't exist. If you're an intermediate metabolizer at 2C9, you have increased levels of phenytoin and an increased risk of side effects. So if you remember, if you go back to that pathway we looked at, phenytoin was really the predictor of whether or not you had dose-related adverse drug events. So that makes sense in this context. Finally, poor metabolizers take it one step further, where you have further increased levels and further increased risk of side effects. Now, one interesting kind of side point here is that the Phenytoin-CPIC guidelines actually involve the HLA-B genetic variation as well. So let's see what that looks like. So if you are a carrier of HLA-B star 1502, then you have an increased risk of Stevens-Johnson's and toxic epidermal necrolysis or necrolysis. And again, this is due to probably some sort of dysfunction on how the HLA-B system is presenting antigens or peptides to the cell surface. So for some reason, phenytoin induces the body's own hypersensitivity reaction to the drug. So what are those recommendations for 2C9 and HLA for phenytoin? So if you're an extensive metabolizer at 2C9, you use as directed because you have those normal levels, that consistent dosing with the guidelines. If you're an intermediate metabolizer, you want to start with a 25% decrease in the dose and then adjust by therapeutic drug monitoring or response. Then finally, if you're a poor metabolizer, you're going to start with an even greater decrease in the dose, this time 50%, and then again adjust by therapeutic drug monitoring and response. And then let's not forget about HLA-B over here. And if you're a carrier, the CPIC guidelines suggest if you're phenytoin naive, aka the patient's never received phenytoin before, do not use. So this just highlights, again, a concept in genetics where not everything is fully penetrant. That's what they call it. Meaning that if you have the 1502 allele, that doesn't necessarily mean that you're going to always get hypersensitivity, Stevens-Johnson's, adverse drug events. You just have an increased risk of it. So there's probably many people out there who have this allele who've been fine on phenytoin. So that's why if they're phenytoin naive, you don't want to use because the risk isn't worth it. If they have been on phenytoin in the past for an extended period of time, it's maybe okay to proceed cautiously, but again, maybe even some people would try to find a new agent. Okay, now that we've covered phenytoin, let's go ahead and switch gears to oxcarbazepine/carbazepine. Let's talk a little bit about the metabolism of this drugs. So in the first part of the metabolism of carbamazepine, you can see it's converted by 3A45 and 2C8 into an epoxide, which then goes into a diol, which then is glucuronidated and prepared for removal from the body. There's also a direct glucuronidation of carbamazepine for preparation for removal from the body. Now let's take a look at the other pathways of metabolism of carbamazepine. And the first part of these additional pathways is again the metabolism of carbamazepine into an epoxide, which is then further metabolized, hydroxylated by CYPs into 2-OH, 2-hydroxy carbamazepine, which then eventually gets changed into aminoquinone. Additionally, there's one final route of carbamazepine metabolism. And that's the metabolism of carbamazepine into the 3-hydroxy form, which then goes into two different paths. One path forms a radical, and the other path forms a catechol into eventually a quinone. And interestingly enough, these two pathways join a little bit here, where the 2-hydroxy form also makes a catechol, and the epoxide form additionally makes 3-hydroxy carbamazepine. So in the end, similar to what we saw with phenytoin, this radical form actually creates adducts here with 3A4, the CYP3A4. So it's hypothesized that this might be one of the mechanisms for the hypersensitivity reactions that we see. So it's a possible mechanism for the hypersensitivity that we observe with oxcarbazepine and carbamazepine. Additionally, there's also the route that I just wanted to highlight here, which is autoinduction that occurs with carbamazepine. We always learn about this, but I don't think we visualize it very often. And this autoinduction occurs via these two genes or proteins here called nuclear receptor proteins. And they actually upregulate the gene expression of 3A4/5. And so that's why we get actual autoinduction of carbamazepine doing it to itself. So I just thought that was an interesting side point. However, what we're concentrating here with the CPIC guidelines is the possibility for hypersensitivity reactions. So now that we've got our slide set up here for the pharmacogenetic effects on carbamazepine, let's take a look at what HLA genotypes do here to carbamazepine. And so, interestingly enough, we're actually going to talk about two HLA genotypes. That's why I didn't write HLA-B like we saw with phenytoin, because there's two different types. Let's also finish this setup. So because we're going to be looking at two different HLA genotypes, I'm going to split the slide in two. And let's see what those genotypes are. So the first gene that we're going to talk about, and specifically variant, is HLA*3101. So if you're negative for that, the risk for Stevens-Johnson's or TEN is considered normal. However, if you're positive for HLA*3101, then you have an increased risk of Stevens-Johnson's or hypersensitivity reactions. Similarly, like we saw with phenytoin, if you are negative for HLA-B*1502, then you have a normal risk for the hypersensitivity reactions. Additionally, what we see here is that these effects also apply to oxcarbamazepine, so we can go ahead and add that in here. However, the HLA*3101 does not apply to oxcarbazepine, so that's why I didn't add it in up there. So just be aware of that. So it's the same exact outcomes and recommendations. Then obviously, if you are positive for HLA-B*1502, you have an increased risk of hypersensitivity reactions with carbamazepine or oxcarbazepine. So let's see how those pharmacogenetic effects of HLA*3101 and HLA-B*1502 translate into CPIC recommendations. So for carbamazepine only, if you're *3101 negative, so you're not a carrier, you're going to use as directed. And if you are positive, it's a little more detailed in the recommendation. If you're carbamazepine naive, they want you to try an alternative. However, they have some other recommendations here as well. Let's see what those are. And those are, if you must use it, they recommend you increase the clinical monitoring and stop at the first sign of any sort of hypersensitivity reaction. However, they also say if you're positive for *3101, but the patient's been on it previously for greater than 3 months, you can proceed cautiously. So the reason they say greater than 3 months is because the cutaneous reactions generally aren't necessarily well correlated to the time on the drug, other than the majority of the hypersensitivity reactions that occur with carbamazepine or oxcarbazepine occur within 3 months. So if a patient's been on it for longer than that, it's very likely that they can basically handle the drug without significant risk of hypersensitivity reactions. However, they still recommend you proceed very cautiously because it could happen. Now, what about carbamazepine and oxcarbazepine and HLA-B? So if you're negative, if you're not a carrier, you're going to use as directed, as we expected. However, if you're a carrier of *1502 for HLA-B, you're going to avoid it if you're naive. So if a patient hasn't been on it previously, they suggest you try a different type of anti-epileptic. But if they've been on it for greater than 3 months, similarly to what we saw in the previous recommendation with *3101, you can proceed very cautiously. So the only other recommendation that the CPIC guidelines tell you is that tolerance to a previous agent is not cross-cutting with aromatic antiepileptics. What this means is that just because you are tolerant of carbamazepine doesn't necessarily mean that you're at zero risk for Stevens-Johnson's or hypersensitivity reactions with oxcarbazepine. So they always tell you to be cautious when switching to different agents because the risk is never zero, even if they've successfully been on other aromatic antiepileptics. Okay, now that we've talked about psychiatry and neurology for applied pharmacogenetics, let's make the big switch and talk about a few examples in cancer. So the first one we're going to talk about is tamoxifen. So let's go ahead and take a look at tamoxifan's PK with the following note. And that's the metabolism of tamoxifen is pretty darn complicated. And what I'm showing you is going to be a very simplified form. So if you're really interested in tamoxifen, if you want to get into the weeds, go ahead and look it up and look into the pathways that PharmGKB will give you because it's pretty advanced. So let's start with the tamoxifen metabolism. And so tamoxifen is metabolized by two primary routes. The first upper one here that we're looking at accounts for about 7% of metabolism, and that's through CYP2D6. So this is an important gene that we're going to be talking about in these CPIC guidelines into 4-OH tamoxifen. And then the other route is through 3A45 and other CYPs for both of these actually. And this one is about 92% of the metabolism of tamoxifen into N-desmethyl tamoxifen. Then finally, these two metabolites are actually transformed kind of in a flip. First 4-OH by 3A4 and N-desmethyl tamoxifen by 2D6 into endoxifen, which then is demethylated into norendoxifen. And so why is the critical reason that we're showing all of this is because when we look at the PK side, in the PK side, meaning the actual therapeutic efficacy of tamoxifen, what we actually see is that all of these metabolites have therapeutic efficacy or have the anti-estrogenic effects that we expect in the cancers that this is used for, primarily breast cancer. So this is why this metabolism pathway is actually pretty important, because although they don't have the same degree of potency of being an anti-estrogenic compound, each of these compounds, 1, 2, 3, 4, and 5, have actual anti-estrogenic effects. So really interesting metabolism. But for the CPIC guidelines, we're going to talk about CYP2D6 today. So we're going to use a similar slide that we've already used. So based on CYP2D6, let's see what the pharmacogenetic effects are on tamoxifen. So if you're an ultra-rapid metabolizer with an activity score greater than 2, you have what's considered therapeutic endoxifen concentrations. So essentially what this means is that these guidelines are showing you that endoxifen, which actually has a higher potent effect on the tumor cells, you have adequate therapeutic concentrations of what would be considered the primary metabolite for therapeutic action of tamoxifen. Now let's take a look at being an extensive metabolizer of CYP2D6, which means you have an activity score of 1.5 to 2. And again, therapeutic endoxifen concentrations. Now let's start to take a look at these kind of in-between phenotypes that we've already talked about, and really there's argument on whether or not you should be categorized as an extensive or an intermediate metabolizer, but really the defining features here are an activity score of 1, and this one has no star 10 allele. So what is the effect here? And that's that these particular phenotypes have a decrease in doxepin levels, meaning an increased risk of failure because there's less metabolism into this form. So an increased risk of failure compared to the extensive metabolizer. And what we see for the next one down, extensive or intermediate metabolizer with the star 10 allele present, is the same. So decrease in doxepin levels, increased risk of failure. And if you are the actual intermediate metabolizer with an activity score of 0.5, again, it's the same. So decrease in doxepin levels, increased risk of failure versus extensive metabolizers. And then finally, what about poor metabolizer with an activity score of 0? Basically, you're having very little metabolism by that route we talked about, which ends up into endoxifen. And this one is the same. You have really decrease in doxepin levels. You don't have 0, right, because there was 2 different pathways we saw that turn tamoxifen into endoxifen. However, you do have decreased levels and you have an increased risk of failure. Now let's take a look at how those pharmacogenetic effects of CYP2D6 on tamoxifen translate into actual recommendations. And for ultra-rapid metabolizer, it's used as directed. Avoid any moderate or strong 2D6 inhibitors. For an extensive metabolizer, it's the same recommendation, so use as directed. Avoid those moderate or strong 2D6 inhibitors. Why? Because again, you're going to have less endoxifen levels. You're basically, what you're creating, what we talked about previously, is a pseudo intermediate or a pseudo poor metabolizer if you have 2D6 inhibitors on board. Now let's take a look at what the recommendations are for intermediate metabolizers all the way down to poor metabolizers. So this recommendation is a little bit longer for the intermediate metabolizer with an activity score of 1.0 with no star 10 allele present. So what they tell you is to consider an aromatase inhibitor alone for postmenopause or an aromatase inhibitor with ovarian functional depression treatment for premenopausal patients. And the reason they do this is because it's superior regardless of your CYP2D6 genotype, meaning that it's not dependent on all this 2D6 effects that we're talking about. So something that likely can be applied to any sort of metabolizer phenotype. However, if tamoxifen is actually necessary, possibly due to a contraindication to aromatase inhibitors, then you want to consider a dose increase and avoid weak all the way to strong 2D6 inhibitors. So what does it look like for the rest of the extensive intermediate with star 10 allele, intermediate metabolizer? So all that writing was worth it because it's the same recommendations. And finally, what are the recommendations for a poor metabolizer? And that recommendation is the same, with the caveat that evidence suggests that a switch here from tamoxifen to an aromatase inhibitor such as anastrozole does not increase the risk of recurrence. So again, looking at the CPIC recommendations, if you're an ultra-rapid or extensive metabolizer for 2D6, you probably can go ahead and use tamoxifen. However, it looks like there's other therapies that are superior to tamoxifen regardless of 2D6 that should be considered for anything that's not an ultra-rapid or extensive metabolizer. Now let's talk a little bit about the pharmacogenetics of fluoropyrimidines, and specifically with the DPYD gene. So first, let's talk a little bit about the 3 fluoropyrimidines that we're going to go over in this guideline. And those 3 fluoropyrimidines are tegafor, fluorouracil, and capecitabine. So let's take a look at how these kind of interact because their metabolism is common with each other. So each of these fluoropyrimidines are prodrugs, meaning that they need to be activated. However, they also have common metabolism where they each go to become 5-fluorouracil. Capecitabine is metabolized by carboxyl esterases 1 and 2 to make 5-deoxy-5-fluorocytidine, and that's metabolized further to make 5-deoxy-5-fluorouracil, which is finally converted into 5-fluorouracil. Similarly, on the other side, with tegafor, that's metabolized by 2D6 initially into 5-hydroxytegafor, and then that's eventually metabolized into 5-fluorouracil. So then let's take a look at what this common metabolite between all three drugs, or the actual drug 5-fluorouracil, what happens here in terms of the metabolism and the mechanism of action. And on one path here, 5-fluorouracil is metabolized by the gene in question that we're talking about in the CPIC guidelines, which is dihydropyrimidine dehydrogenase. And this is actually the rate-limiting metabolism step, so that's why it's so critical to the clinical outcomes that we're going to talk about. And that's metabolized into dihydrofluorouracil, which is then further metabolized and removed from the body. Let's take a look at some of the other paths of 5-fluorouracil metabolism. And what occurs here is the activation of 5-fluorouracil in two different steps here, or two different pathways. One pathway activates 5-fluorouracil into fluorouridine triphosphate. The other pathway activates it into fluorodeoxyuridine monophosphate, which is then further metabolized into fluorodeoxyuridine triphosphate. And then this is where these three different metabolites actually have the pharmacodynamic or therapeutic effects of fluoropyrimidines. And let's see what those are. Fluorouridine triphosphate gets incorporated into RNA, which then causes cell death. And on the flip side, the fluorodeoxyuridine triphosphate gets incorporated into DNA, which causes cell death. And remember, this is for cancer, so it would be cell death of the tumor. And then finally, the fluorodeoxyuridine monophosphate actually goes in and blocks thymidylate synthase, which then blocks the folate cycle and the production of methionine. So therefore, it's also a method to prevent the DNA replication of the tumor. So now that we have the metabolism and mechanism of action of fluoropyrimidines under our belt, let's take a look at the pharmacogenetic effects of DPYD on fluoropyrimidines. And for DPYD, we can look at metabolizer phenotypes. So first, let's look at normal metabolizers. And if you're a normal metabolizer genotype and therefore phenotype of DPYD, the gene, you have normal activity of the enzyme DPYD and therefore a normal risk of toxicity from fluoropyrimidines. Let's take a look at what would happen if you're an intermediate metabolizer at DPYD. And if you're an intermediate metabolizer of DPYD, you have decreased activity of that enzyme, anywhere from 30 to 70% decreased activity, and an increased risk of severe or fatal toxicities. Finally, let's take a look at poor metabolizers. And if you're a poor metabolizer, you have actually no DPYD activity, therefore you have no metabolism at that rate limiting step we talked about, and you probably have an even further increased risk of severe toxicity and possibly fatal toxicity. Now let's take a look at what those pharmacogenetic effects actually do in terms of genetic or genetically based recommendations for the fluoropyrimidines. So first, let's start with normal metabolizer, as we always do. And as you expect, and as we see for most of the CPIC guidelines, if you're a normal metabolizer, you use as directed. Now let's take a look at what the recommendation is for intermediate metabolizer. And that would be if you're an activity score of 1.5, you want to decrease the dose by 25%. If you have an activity score of 1.0, you decrease the dose by 50%. And they always advise you titrate based on toxicity and use therapeutic drug monitoring if available. And one thing I will say here is I encourage you to go to the CPIC guidelines to take a look at what makes up the DPYD gene variation and translation into the phenotypes, because it's a little bit different than what we technically or generally see with CYP or other star alleles, genotypes and phenotypes that we've been talking about. So go ahead and look in the table 1 of the CPIC guidelines. That'll tell you kind of the actual variants they're talking about and how they translate those into phenotypes. But with that being said, let's go ahead and transfer to poor metabolizers and see what the recommendation is there. And if you are a poor metabolizer with an activity score of 0.5, they tell you to avoid use. But if it's absolutely necessary for some reason, whatever that clinical indication may be, they recommend you severely, and this is the wording they use in the guidelines, decrease the dose and use therapeutic drug monitoring. While if you're an activity score of 0, they blanket recommend that you avoid it. So there are your recommendations for fluoropyrimidine and the DPYD gene. Now let's go through our final cancer applied pharmacogenetic example for today, and that's with thiopurines. So let's go ahead and take a look at thiopurine metabolism and therapeutic effects. And the 3 drugs that we're going to talk about in terms of thiopurines are azathioprine, mercaptopurine, and 6-thioguanine. And azathioprine and mercaptopurine are actually related in that azathioprine is metabolized by glutathione S transferases into mercaptopurine. And each of these thiopurines are actually transported into the cell by particular transporters that we've talked about many times so far called SLC transporters. So we can see they've come into the cell now, mercaptopurine and 6-thioguanine. Mercaptopurine is metabolized in 2 different paths. And one path is by the thiopurine methyltransferase, which is one of the genes that we'll be talking about in this CPIC guideline, into methylmercaptopurine. And the other pathway is into thioinosine monophosphate. Thioinosine monophosphate is then further metabolized. And then the metabolism for 6-thioguanine actually interacts with the metabolism of mercaptopurine through thioinosine monophosphate here. And that conversion is where 6-thioguanine is turned into thioguanosine monophosphate, which is the same thing that happens to TIMP. And then further phosphate groups are added on to thioguanosine monophosphate. And furthermore, TGMP is metabolized by thiopurine methyltransferase, which again is part of our CPIC guidelines, into methyl thioguanosine monophosphate. Now let's highlight the one last gene that's part of the CPIC guideline, and that's here with thioguanosine triphosphate. And its kind of conversion back into monophosphate by the gene NUDT15, also called Nudix type motif 15. Now let's take a look at what the actual pharmacodynamic and therapeutic effects of all this metabolism of the thiopurines is. First, pharmacodynamic and therapeutic effect is with TIMP, and it becomes an anti-metabolite in the folate pathway, just like the folate pathway we talked about with the previous CPIC guidelines, and that directly has to do with TPMT. So again, this is where TPMT comes in on this guideline. Furthermore, methylated TIMP actually inhibits de novo purine synthesis, therefore stopping DNA replication. Additionally, on all of this metabolism, there's further effects with thioguanosine diphosphate. And that's where thioguanosine diphosphate is changed into thioguanosine or thiodeoxyguanosine triphosphate. And thiodeoxyguanosine triphosphate is again reduced in its phosphate groups by NUDT15 or Nudix type motif 15. So again, this is the other gene in the guidelines here. But the guanosine triphosphate itself causes DNA damage and apoptosis. And then the final mechanism of action occurs here with the thioguanosine triphosphate. And that's where it has two effects, one being with RAC1 mediated apoptosis of the cell, and then incorporation into RNA, causing RNA damage and cell death. So we can see here the three thiopurines have a common metabolic pathway where they actually have their pharmacodynamic or therapeutic effects mostly in common, except for thioguanine has some differing effects where they don't go down the pathway of TIMP. So let's go ahead and see what the pharmacogenetic effects on this initial slide will be with the thiopurines, specifically with TPMT. So if you're a normal metabolizer of TPMT with the thiopurines, the pharmacogenetic effect is a decrease in the TGN metabolites occurs with a normal metabolizer with an increase in the methylated TIMP form, and this is considered the normal pattern with thiopurine treatment. And with that, you have a normal risk of leukopenia, neutropenia, and myelosuppression, or what I'm going to shorthand from now on, LNM. But of note, there's actually a 5 to 10 times increase of the TGN metabolites with thioguanine as compared to the other two drugs. So that's just a note that they have in the guidelines. Let's see the pharmacogenetic effects of intermediate metabolizer of TPMT. And with an intermediate metabolizer, you actually have increased TGN metabolites in this scenario with a decrease in the methylated TIMP form. And this causes an increased risk of leukopenia, neutropenia, and myelosuppression. And again, the other note here is that the TGN metabolites are 5 to 10 times higher with thioguanine. Finally, let's take a look at poor metabolizers. And that's severely elevated TGN metabolites, again, because they're not being metabolized well by TPMT. You have no methylated TIMP, which TPMT actually produces, and therefore you have a severely increased risk of leukopenia, neutropenia, and myelosuppression, and in fact it will be fatal without a dose decrease. Now let's look at the pharmacogenetic effects of NUDT15, that Nudix type motif 15 gene. And this is another guidelines where I suggest you go to the CPIC guidelines itself to look at how they define the genotypes of each of these genes and how they actually define the metabolizer phenotypes that go along with those genotypes. But what is the pharmacogenetic effect of a normal metabolizer? You have a normal risk of leukopenia, neutropenia, and myelosuppression. If you're an intermediate metabolizer of the NUDT15 gene, you have an increased risk of leukopenia, neutropenia, and myelosuppression. Then finally, if you are a poor metabolizer of the NUDT15 gene, as you may have guessed, you have a much higher increased risk of leukopenia, neutropenia, and myelosuppression. And again, that's due to the lack of metabolism from those triphosphate forms back down to the monophosphate metabolite forms. So there are the pharmacogenetic effects of NUDT15. Now let's look at what the actual recommendations are based on those pharmacogenetic effects. And this is going to be combined recommendations based on either TPMT or NUDT15. In the CPIC guidelines, they actually provide you with 2 recommendation tables. However, here I'm going to consolidate them because they're very similar. And for normal metabolizers of TPMT or NUDT15, you're going to go ahead and start with a normal dose for each of the drugs listed here, each of the thiopurines, and allow 2 weeks between adjustments. Let's take a look at what the recommendation is for intermediate metabolizers. And that's to decrease the dose 30 to 80% for azathioprine or mercaptopurine, 50 to 80% for thioguanine, adjust every 2 to 4 weeks based on myelosuppression guidelines, and if myelosuppression occurs, to decrease mercaptopurine or thioguanine over other drugs first. Let's take a look at poor metabolizer recommendations. And for malignancies, you decrease the dose at least tenfold and give 3 times a week, so drastically reducing the dose and spreading out the dosing. You adjust it every 4 to 6 weeks as detailed above in intermediate metabolizer. So 4 to 6 weeks based on myelosuppression guidelines, and then if myelosuppression occurs, just like with intermediate metabolizer, you want to decrease mercaptopurine and thioguanine over other agents. Then for non-malignancy with poor metabolizers, they just suggest you consider an alternative non-thiopurine metabolism. So that wraps up our second application session on pharmacogenetics. I hope that this gave you at least some insight into all the guidelines that exist. There's many, many more that I did not go over. So if you have drugs of interest, topics of interest, areas of interest, go ahead and look into the guidelines and PharmGKB to find what pharmacogenetic evidence exists, if any, out there. Thank you.